This is an overview of a patient who, as you can see, has severe periodontal disease, pyorrhea, expulsive periodontitis, with some teeth extruded from the socket and extremely mobile. We have atrophy of the upper jaw with a very low maxillary sinus. So here we have just 3 to 4 millimeters of bone depth, as in this area as well. We're talking about the upper jaw. After the examination, I made a plan for 2 pterygoid implants positioned like this, 2 nasal implants positioned like this, obviously 19 millimeters long. So the pterygoid implant, a 10 or 12 millimeter implant, is not a pterygoid implant. It's a tuberal implant in the tuber. In fact, I see quite a few pseudopterygoid implants that are 12 or 13 millimeters long. It's a fake pterygoid that only rests in the tuber. A true pterygoid implant must be at least 19 millimeters long, as we'll see from the post-op X-ray.
Of course.
So the plan was to have the extractions done and temporarily keep these 2 central ones, 2 pterygoids, 2 nasals, and then whatever else in positions 12 and 22. With bone grafting. In this area, I did a lot of bone grafting because we had a vertical bone deficit. Can you turn it off? Sorry. So, as for the mandible, we extracted the lower incisors, placed an implant in the molar area, another in the molar area, and these 2 implants that the patient had done many years ago and that have some bone resorption. I left them in place because at the next checkup I need to perform a lift. What does it mean to do a lift on an implant that has peri-implantitis? An implant that has perfect apical osseointegration. Removing it means you have to core out the bone. So what happens? If we already have a bone deficit and we core out the bone here, we end up removing all of the patient's bone.
Of course.
So what did we do? Nothing.
Of course.
In other words, we just kept making things worse for her. So I will treat the threads, decontaminate them, smooth them, remove them, clean all the bone, and do a bone graft with a membrane, and the implant will remain stable. I placed an implant in a position that's considered the back. For us doctors and for the average person, it's in the back, in this position to support these, also with 2 implants so they're not alone, to avoid excessive chewing load that could eventually lead to bone resorption.
Yes.
Well, the procedure lasted 3.5 hours. We completed everything. Can you change the X-ray for me now? Can you put up the X-ray with the implants? Here, this is the post-op image where you can see the pterygoid implant, the nasal implant, which, I repeat, are both 19 millimeters. 2 implants in the positions of the right and left lateral incisors, and on the other side, a pterygoid and a nasal implant. On the lower jaw, the implants I had planned. Okay?
Yes.
So, the day after, a provisional screw-retained prosthesis was placed on some of the implants, and the patient, after just 1 day. She was operated on yesterday? After 1 day, exactly. Now let's see the patient in the chair. She has a fixed provisional prosthesis.
Good evening.
And I avoided making a temporary denture prosthesis so that, because the patient's social life would have been ruined for 6 months, with a full denture, with glue and so on. It should be noted that after the surgery, The patient has resorbable sutures. Before 25 to 30 days, they don't dissolve, the tissues don't heal, and putting in a denture can cause complications like reopening of the flap wound and therefore infection, which could lead to loss of the implants. So she would have to go a month without the denture, and only after a month could she get the denture. Just imagine the discomfort, the inconvenience for the patient in her social life. Because even a housewife who stays at home has a social life with her husband, with her children, and she would have to hide, lock herself away at home with a mask just so her own family doesn't see her. So we really achieved great success by placing a fixed, screw-retained temporary prosthesis just one day later, which is a prosthesis. As we can see now, that really, here is the patient now. As you can see, it almost looks like we didn't do anything yesterday, like it was all just a dream. But it's real. A star is born.
That's absolutely true.
So she can smile, close her mouth, and smile. You can see the smile line. In one day. In Italy, not in Albania, not in Romania, not in Turkey. Why? Because here there's quality. Here, they would have made a fixed Toronto prosthesis with artificial gum. But here, you can see that the prosthesis comes from the patient's natural gum.
Of course.
Plus, it's cleanable and can be treated with mouthwashes. Whereas with artificial gum, all sorts of microscopic dirt gets trapped.
So, Professor, let's recap. Yesterday, the patient came in with severe atrophy. You performed a surgery of about 2.5 hours. You did both the upper and lower jaw with your pterygids. And this afternoon, the day after, the patient has a fixed set of teeth like this, without artificial gum?
Yes.
I can't believe it.
So we have, no, this is reality because you can follow. Many times people say, yeah, but I can go there and spend half as much. Okay, but let's look at the quality of the work. Let's also look at the predictability of the work. Because doing all on for implants, 5 implants, short ones, and so on, they get lost over time. The prosthesis isn't stable, and it's a job that doesn't last long.
Of course.
I've been doing pterygid implants for 35 years. Maybe some implants fail, but the pterygids are there forever.
Of course.
Why? Because the pterygid implant is inserted through the tuberosity, which is a spongy bone that's really soft, and it goes into the pyramidal portion of the palatine bone, which is a type 1 bone. It's a cranial bone that doesn't resorb. So, while the maxilla can resorb, the palatine bone, specifically the pyramidal portion of the palatine bone, is enclosed between the wings of the sphenoid, the lateral and medial plates. Basically, this is an implant placed in a type 1 hard bone that doesn't resorb and isn't part of the maxilla or the mandible. The skull, the frontal bone, the parietal, the occipital, they don't resorb.
Of course they don't resorb.
The vault of the palate doesn't resorb.
Of course.
So the idea is this, to place implants and pillars of resistance. And in the skull, the pillars of resistance are the zygomatic pillar, the canine pillar that we used where we placed the nasal implant and the pterygid implant. The other one is the zygomatic implant. But in this case, I'm not going to do the zygomatic implant. I also perform pterygid, zygomatic, and subperiosteal implants. Depending on the case, This patient does not require other very advanced surgical techniques. A lot of morbidity. What does morbidity mean? You have to open up a lot, all the way under the eye, to insert the zygomatic implant, which needs to be checked for the orbital cavity, so it's a very serious procedure. But you have to open up a lot, and for the first 10 days the patient is a bit handicapped with swelling, bruising, and so on. But beyond that, every maxilla has to be interpreted based on how it presents itself. So never just use one technique, like, I know how to do the zygomatic implant, so I do it for everyone. No, you need to perform a surgical technique tailored to that patient's maxilla, aiming for the fewest possible complications. Here, we could have done a major sinus lift on both the right and left sides, which I do perform. But if I manage to complete all that surgery in 2.5 hours, what does that mean compared to a bone graft of the maxillary sinus? You have to open the maxillary sinus. You have to lift the membrane. And for the bone graft, if the membrane tears, you have to stop because you need to close up and you can't continue the procedure. Otherwise, the material will disperse into the sinus and you could get sinusitis, aspergillosis, fundal sinusitis, and so on. So, an intraoperative complication. After 6 months, you place the implants, then another 6 months. For a whole year, the patient is left without
teeth, basically.
But here, after just 1 day, we have this result, so you can really see the difference between surgical techniques. That's why we choose the one with the fewest possible complications and the best, fastest aesthetic results. After just 1 day, hands up if anyone else can deliver that in a day. If I'm not mistaken, the patient went shopping in Padua yesterday. So you can understand what the secret is, and I won't reveal it, because otherwise my technique, my surgical method, well, there is a secret to making patients feel good.
Absolutely. But that's exactly why we're talking about this. To inform patients and show them the solutions your techniques offer. Because unfortunately, Professor, they just don't know about them.
Well, things are evolving now, but I've been doing this for 35 years, and I think I'm one of the few in Italy with such an outstanding track record. Just recently, a dentist from Novara called me and said, please, teach me the Tarragood technique. I want to come to your school. I told him, hold on, because to learn this technique, I really had to sweat blood and study a lot. I went to America, to France, to university sessions on cadavers, dissecting cadavers over and over, and really getting to know the anatomy. But now, I have the anatomy right here in my head. I don't need a CT scan. With that, I'll say goodbye, madam. I wish you the best. Have a safe trip to Turin, and I'll see you at your checkup.
Thank you very much, Professor. Give us a nice smile, dear Donatella, just like I always say.